Welcome to this explainer, where we're going to treat the human mouth a little bit like the scene of a crime. We're investigating a biological mystery today that affects millions of people, yet it's usually surrounded by so much embarrassment and misinformation. I'm talking about halitosis. Think of this as your medical detective guide to bad breath. We aren't just going to cover how to mask the scent, we are going to track down the microscopic culprits, examine the systemic clues, and actually solve this problem at its absolute source.
Here's our game plan. We'll look at what halitosis actually is, the intraoral culprits, the extraoral causes, diagnosing the issue, management strategies, and finally wrap up with some high-yield pearls.
All right, let's dive right into Section 1. What is halitosis? The biology behind bad breath. At its core, bad breath is almost always the direct result of oral bacteria. And the primary offenders here are volatile sulfur compounds, or VSCs. These are the main, highly foul-smelling gases produced by these bacteria. It's kind of gross to think about, I know, but basically, microscopic organisms are feasting in your mouth, and these sulfur compounds, that's their metabolic exhaust. So that distinctive odor is literally just pure biology at work. Moving on to Section 2, the main intraoral culprits. Let's look at the usual suspects inside the mouth. Here is our lineup of local intraoral suspects. We've got periodontitis, which is severe gum disease, alongside just generally poor oral hygiene, where plaque and hardened calculus are allowed to build up. Then there are caries, or cavities, and these act as the perfect little food impaction traps, where bacteria can just thrive completely undisturbed. We also have pericoronitis, which is inflammation around partially erupted teeth, and unclean dentures or appliances. Oh, and you definitely can't overlook xerostomia. That's dry mouth. You see, saliva naturally washes away bacteria and debris, right? So when your mouth is dry, you lose that built-in defense mechanism, creating the perfect environment for those sulfur-producing bacteria to multiply like crazy. But out of all these suspects, we have one prime offender. If you take away just one thing about where bad breath comes from today, let it be this: the posterior tongue coating. The very back of the tongue is highly textured and extremely difficult to clean, making it the absolute #1 hiding spot for the bacteria producing those volatile sulfur compounds.
It's really fascinating to contrast these highly common local intraoral culprits, like the tongue coating and periodontitis, with the rarer systemic extraoral causes, things like GERD or DKA. This perfectly illustrates how breath isn't just about what's happening locally in your mouth, it can actually be a massive clue about your broader bodily health.
Which brings us to Section 3, extraoral causes and clues. This is for when the problem goes way beyond the mouth. When we start looking outside the oral cavity, the breath literally acts as a vital alarm bell. We have respiratory tract infections to consider, things like sinusitis, tonsillitis, tonsil stones, or even deep lung infections. But it goes even deeper than that. Gastroesophageal reflux disease, or GERD, can push stomach contents and odors upward. Even more severe, systemic conditions like diabetic ketoacidosis, DKA, or renal and liver failure can manifest with really distinct odors. In these cases, your breath is literally carrying metabolic byproducts from your bloodstream straight out through your lungs. Let's shift to Section 4, diagnosing the issue, how we run the clinical tests. A proper clinical diagnosis always follows a logical step-by-step process. Step 1. Visually check that prime suspect, the posterior tongue coating, and probe for any periodontal pockets. Step 2. Check for caries that might be trapping food, and inspect any dentures. Step 3 involves assessing salivary flow to rule out xerostomia. And Step 4? Well, this is a fascinating one. It's the organoleptic test. What is that exactly? It's a highly practical, albeit very personal, chair-side method where the clinician literally uses their own sense of smell to evaluate the air coming from the patient's mouth and nose. Believe it or not, it remains one of the most reliable ways to initially categorize the type and severity of halitosis.
Okay, Section 5, effective management strategies. How do we solve the problem permanently? Because we know most cases are intraoral, our absolute first-line defenses are mechanical: aggressive tongue cleaning and diligent plaque control. You literally have to physically disrupt the bacterial colonies. From there, management means addressing specific dental needs. This could require professional periodontal therapy to clean out deep gum pockets, restoring caries to eliminate those food traps, ensuring dentures are meticulously cleaned, and medically managing xerostomia to get that natural salivary flow back to healthy levels. Now think about your typical morning routine for a second. A quick swish of mouthwash might feel minty and fresh, but here is a Really crucial point. Mouth rinses are only adjuncts. They are absolutely not definitive treatments. Sure, they might temporarily mask the odor, but if you haven't mechanically cleaned the posterior tongue or treated the underlying periodontitis, those sulfur-producing bacteria are still sitting there perfectly intact. And I promise you, the halitosis is going to return the second that minty flavor fades.
Finally, Section 6, High-Yield Medical Pearls. Let's hit the biggest takeaways.
If we lock just one core fact into our memory from this entire investigation, it's got to be this. The vast, overwhelming majority of halitosis comes directly from the posterior tongue and periodontal pockets. If you address those two specific areas mechanically, you're going to solve the vast majority of cases. Simple as that.
But as medical detectives, we have to be alert for the outliers, right? Fruity breath equals think DKA, not routine halitosis. If a patient's breath smells sweet or fruity, almost like acetone, rather than that foul sulfur smell we discussed earlier, that is a massive red flag for diabetic ketoacidosis. That's a life-threatening medical emergency. It requires immediate systemic intervention, not a toothbrush.
And that brings us to the end of our investigation. Halitosis is rarely just a cosmetic inconvenience. It's a physiological signal. Whether it's pointing to a hidden plaque buildup on the back of your tongue, a dry mouth condition, or even a systemic issue like organ failure or DKA, your mouth is truly a window to the rest of your body. So I'll leave you with this to reflect on. What is your breath trying to tell you about your overall systemic health? Thanks for joining me on this explainer, and keep asking the right questions.